we'll call water, please. Okay, this is the case of a patient who has a history of hypertension, which is controlled, and renal failure, and she's on dialysis, and she complains of dyspnea and dizziness, and comes up into the hospital. I think just one day after she had her last dialysis. And I'll switch now back to the other presentation, and we'll take a look at the case. 1 second. Okay. Good. So her image quality was not so great from a parasternal approach. I'll show you what we have, though. You see immediately that we don't have a very good orientation. The ventricle looks more like an egg than a round structure. So this means we are probably not perpendicular to the imaging plane. But anyway, even if we don't want to make any measurements, put it this way, we cannot make any measurements here, but we can look at left ventricle function. And I want you to judge ventricular function like in your head and figure out what you think ventricular function is. Okay. And now let's turn to the apical views where the image quality is a lot better. Okay, then I have a question here from Amber, who asks if this is uremic pericardial effusion. Well, this is something that you should always consider in patients who have renal failure. It's not an uncommon cause. However, very rarely will you find hemodynamic significant pericardial effusions in patients who have, uremia. And in this case, at least not in these views, I cannot see that there's any form of pericardial effusion. But what I do see is I see that there is significant left ventricular hypertrophy. I can see that there is, I would say, maybe a mild to moderately enlarged left atrium. And then you see heavily calcified annulus, which extends right here into the myocardium. You see this right here? And yeah, how do you think function is? Okay, let's take a different look. The ventricle. Okay, show you another view. Okay, Nico wants to know if this is mitral stenosis. Good question, because annular calcification can certainly obstruct inflow. First, here is a view of mitral inflow with color, and you do see a flow convergence. In other words, yes, absolutely correct. There is some degree of mitral stenosis. The question will be, is it significant or not? And to determine this, here is the continuous wave Doppler through the mitral valve, and we get a pressure half-time of 87, which is fairly low. So it does not really indicate significant mitral stenosis. So if you use this to derive mitral valve area, you would get 2.5. Remember, everything that is below 1 would indicate severe mitral stenosis. Aside from the pressure half-time, one should also look at the mean gradients. Okay, so that's what I'm going to do right here. Okay, so the mean gradient here is 9, which is elevated. Okay, not significantly elevated, so it's still below 15, so we'd say it's not severe. And if you put all this information together, yes, there is some degree of mitral stenosis, but it is not really significant. I would say it's maybe mild to moderate. One other maybe issue that I must mention here, if you perform pressure half-time in a patient who has severe left ventricular hypertrophy and where you can kind of assume diastolic dysfunction, then pressure half-time is not very reliable. But in essence, if we look at the color, if we look at the degree of stenosis, or at least the way the mitral valve moves, and if we also look at the mean gradients, stenosis would probably be mild to moderate and not her only problem. Okay, so coming back to the patient now, remember the main problem the patient had was dizziness. She was tired, fatigued. What do you think is her real problem? Well, I'll just ask the question to you. Do you think that this is due to, I don't know, some problem related to ventricular function, or do you think it is related some way to something else? Well, I'll give you the answer. This is a patient who has hypovolemia. Hypovolemia is something that can cause severe symptoms. And hypovolemia can occur under a number of different settings. It can occur, for example, in patients who have blood loss, trauma patients. And usually we say that if you lose 15 to 30% of blood volume, then which is approximately 750 to 1.5 milliliters, then you really start to get symptoms. This is when you start to be symptomatic. Below that, the heart can kind of compensate. What it does, it increases the heart rate, it increases ejection fraction. But once you reach more than 30% or more than 50% of blood loss, you start to get symptomatic and blood pressure usually drops. Now, another very frequent cause of hypovolemia is our diuretics. Very frequently you have patients who are hypertensive, and one of the typical treatments for hypertensive heart disease are diuretics. So you give them diuretics, and what happens? Okay, they get underfilled ventricles, which essentially causes hypotension, and then very often you would get dyspnea. And then what happens is when you get dyspnea, you give them more diuretics, and you kind of have a vicious cycle where you drain these people and until they have practically no fluids left in their body and no fluid left into the circulatory system. And the reaction is that the ventricle is very small, as we saw in this patient, where we have hypercontractility, and where in essence the patients are severely symptomatic, even though they have normal left ventricle function. Let me show you another example of a typical patient who has hypovolemia, and maybe I'll show you all the typical features you can see in this patient. Well, first of all, what you see is you see a small ventricle. Okay, so the ventricle is small. It's usually hyperdynamic. The patients usually have rather high heart rates, and the atria, they are usually relatively small, but sometimes they're also normal or even enlarged because the patient has some other underlying condition like atrial fibrillation. And very typically what you will find is you'll find flow acceleration within the ventricle. If you place the color Doppler within the ventricle, you'll see a lot of color, simply because the blood is moving very quickly. It's being ejected quickly, but there's not enough volume inside. And if you put a pulse wave Doppler in here, you will see a typical spectrum which looks like the spectrum you have in an apical squeeze, where you have a very late flow acceleration curve within the ventricle. So this is what you can expect in such patients. And to really assess volume, you should always look at the inferior vena cava, because if the inferior vena cava is very small, or maybe even not even measurable or completely collapsed, this is an indication for hypovolemia. And something else that you should be aware of, that many times patients with hypovolemia have fairly large A waves. Let me go back to this patient that I just showed you before and show you maybe a few different features on this patient again. Let's take a look at her pulse wave Doppler across the mitral valve. Well, why is the A wave so high? The reason is very simple. She has a kind of an underfilled left atrium, so a lot of blood is still in the left atrium at the time of atrial contraction, which means that at that time we have a lot of blood being expelled into the left ventricle. So you can sometimes see very, very high A waves and very small E waves in the setting of hypovolemia. And one thing that I also want to show you in this patient, we're discussing about how good is left ventricle function. We calculated ejection fraction above 80, but in essence, and most of you who've seen my lectures before will know that this is something I always mention. In essence, we are overestimating ejection fraction in patients who have small ventricles. If you look at longitudinal function, it is actually very poor. As a matter of fact, it's especially poor at the base, and normal or maybe hypercontractile at the apex. This is an abnormal pattern. This means that this patient already has some degree of left ventricular dysfunction. And if we just look at ejection fraction, we're really going to miss this. Okay, so yeah. Alex mentioned something, and I think this is exactly something that, actually something I forgot to say. He says, I think that hypovolemia is related to dialysis in this patient. And I completely agree with Alex. This patient, is 1 day after dialysis, and it just, took all the fluid out of this patient, and this is why the symptoms actually occurred. So, very good comment from Alex. Let's go to the next case. Okay, yeah, just one slide that maybe summarizes some of the problems you have in hypovolemia. Look out for hypovolemia, especially in patients who have left ventricular hypertrophy. They already have small ventricles, which are very difficult to fill. And if you don't have enough preload in these patients, you will get very small ventricles and symptoms of hypovolemia. Look at patients who are after cardiovascular surgery, especially aortic valve replacement for aortic stenosis, because they have very stiff ventricles and small ventricles as well. So this is something you will encounter in such patients very frequently, and where you have to really, really be cautious not to give them too many diuretics. Okay,